Okay, hello everyone. Thank you for joining us for this month's webinar on tools for building institutional trust with Jennifer Stevens from America's Essential Hospitals. Before we begin, let me cover a few logistics. This meeting will be recorded and shared. While our presenters are speaking, we will have the lines muted to reduce unnecessary noise. We will unmute at the end of the presentation for questions and comments. Please feel free to enter questions into the chat box throughout the presentation. Now let me turn it over to Daniel Wolfson.
Welcome, everybody. We really have a gem of a person today to talk about trust and what she's learned in her research about trust. As many of you know, that we are evolving our agenda in the ABIM Foundation to trust, and we're really happy to have Jennifer with us today. She's a former principal investigator at America's Essential Hospitals, and she is a 2018 grantee of Robert Wood Johnson Foundation's Building Trust and Mutual Respect to Improve Health Program managed by Academy Health. Every time I sit down with Jennifer, I learn a lot, and I think you will too today. We're going to have a short presentation of 25 minutes, and then I'm going to have some questions, and we're going to have a little conversation, and then we'll pass it over to you to have Q&A and have a good conversation. So Jennifer, take it away, please. Welcome.
Thank you so much for that introduction, Daniel. I really appreciate it. I am looking forward to sharing not just our findings from research, but our guide. We're very lucky at America's Essential Hospitals and the Essential Hospitals Institute to be able to talk about trust. As you know, it continues to be an issue, whether it's around a COVID-19 vaccine, testing, being willing to go and get care, or just following the instructions of your doctor, for example. Before I get into the meat of it, I want to take a moment and highlight our project staff. In particular, I want to highlight my co-PI who's on the line today, Dr. Kalpana Ramia, who's our Vice President of Innovation and Director of Essential Hospitals Institute, as well as my colleagues, Dana Clark and Hannah Lambalot, who were incredibly supportive in helping us to achieve the goals of this project. They are not the only folks I have to offer thanks to. I certainly wouldn't be here without the support of the patients, caregivers, and staff at our 3 member hospitals in Orlando, Indianapolis, and Los Angeles. The Robert Wood Johnson Foundation, who funded this work, and Academy Health, who supported it, the Essential Hospitals Institute Board of Directors and our research committee, as well as our staff and consultants who lended an ear, a hand, and their expertise along the way to help us get to where we are. Perhaps you've heard of us, America's Essential Hospitals, but just in case not, I think it's important for me to just take a beat and explain who we are. America's Essential Hospitals, you might actually know us by another name. Pre-2013, we are NAPH, or National Association of Public Hospitals. We are 300 nonprofit and public hospitals across the country, representing 38 states and the district. We highlight that we care for the most vulnerable, and we're where you go when you have severe needs, for example, like trauma, you need a burn unit, a NICU, or in psychiatric inpatient, for example. We're also responsible for doing a lot of health professional training. In addition to over a third of our hospitals being academic medical centers, 78% of our hospitals are actually teaching institutions. And we don't just do acute care, there's both primary and specialty care networks and a commitment to coordinated care at our member hospitals. You've heard me talk about how our hospitals serve the most vulnerable. As you look at this graphic, you'll see these red dots. The red dots indicate where a member hospital exists. What is interesting to look at this is, as you look at where our hospitals exist, in many respects, those hospitals are in those same darker blue areas. The darker the blue area, the higher the CDC Social Vulnerability Index is. And so you can see that, again, not only do we talk about serving the most vulnerable, we are represented in those areas where the most vulnerable live. We're part of those communities. When we talk about those communities of need, we're talking about folks who are inequitably impacted by social determinants of health, whether that be about homelessness, living below the poverty line, or being part of a racial ethnic minority group or a person of color. So our hospitals are seeing a high proportion of folks with those categories. And so as we took to this project, we were very keen on looking at trust for vulnerable populations. Now, trust is not new. It's been studied before, certainly. But we wanted to hear from patients about what's the most important dimension of trust to them. You know, trust is a very short word that means a lot of different things. So what does it mean to you as a patient who goes to an essential hospital? We also, though, didn't want to just learn about it. So we wanted to understand what are those policies and practices that hospitals can undertake that can help build and promote trust, so that they can continue to work and create greater trust among their communities. To do this, we decided we were going to do 3 major activities. The first being a patient survey, the second, a series of 3 site visits, and then finally taking the findings from those 2 items and putting it into a guide that could be used by our member hospitals. Let's talk about that survey. The survey was for patients and caregivers, and we were keen on making sure that we were identifying, again, what those dimensions, what are those factors that patients at our hospitals find to be most important. In addition to finding those factors, though, we were also going to make sure we captured what's the overall trust in each hospital that's visited, so that we could get a sense of what's the overall trust of essential hospitals. Like most research projects, we started by doing a literature review. We didn't want to reinvent the wheel. We didn't have the time or money to do so. So we started with, what do we know about trust, and what questions can we borrow from established, valid surveys that are already out there? We knew, though, there were some items that were new that we were adding to the survey. So we also were trying to capture where those questions were asked on other surveys. And for that reason, we also felt that it was important to cognitively test the survey. So we set out to do interviews with patients and caregivers from essential hospitals to make sure that the questions were both valid and reliable and understandable to patients. Ultimately, the survey was about 96 questions, and using a market research firm, each participant received approximately $1.50 for completing the survey. It turns out that patients and caregivers do trust essential hospitals, averaging an 8 out of 10 to the question, how much do you trust this hospital? In addition, we were pleased to see this because 1,000 patients and caregivers responded, primarily patients though. They represented 231 of our 300 members. And at the time, we were represented 41 states in the district in this survey. We also were keen on looking at where the insurance coverage was. In our hospitals, we see primarily Medicare and Medicaid patients. And similarly, in this survey, we had most of our responses come from Medicare, Medicaid, and self-pay patients. What we also found is that overall trust, it's not consistent by demographics. It certainly is higher among certain groups, particularly men, folks who identified as white or other race, non-Hispanics, older participants, those with greater than $50,000 per year income, those with higher education, high school or greater, Medicare recipients, and folks who had a scheduled hospital visit as opposed to an emergency unplanned visit. We also found that our larger hospitals, those with more than those 548 beds, that was the average number of hospitals, tended to score higher than those smaller hospitals. We looked at 7 dimensions of trust. We looked at fidelity, that's that commitment to patients, that advocacy for patients, honesty, that transparency or truthfulness, confidentiality, keeping what's private, private, Competency, everyone wants to get high quality and safe care when they go into the hospital. Equity, fair and equal treatment across a number of different demographics, including race, ethnicity, age, religion, culture, body size, and additional items. Community integration, looking at social connectedness, addressing social determinants of health, and connectedness with the community in general. And finally, environmental quality. Now, the environmental quality piece is that, well, is it not just quiet and clean, but also is it laid out well? Is it easy to navigate? Things of that sort. The top 4 items, fidelity, honesty, confidentiality, and competence, are probably very familiar to you. They are well-established factors or dimensions of trust. But as we, again, were focused on essential hospitals, those who serve a safety net role, we wanted to think about what other dimensions might be important to patients at those hospitals. And that's where the equity, community integration, environmental quality come in. So we hypothesized that these would be important. And at this time, I'd like to ask you, what do you think was in the, let's say, the top 3 trust dimensions? And you only have to get one of them right. So we're going to launch a poll now. I think Kate's going to launch it for me. Great. It would be unfair for me to take the poll, but I'm going to. As you're taking the poll, I'll continue to tell you a little bit about, hold on. I think it might have closed early before you got a chance to respond. As you're taking the poll, I will continue to go through and describe what we did to understand a bit about what those dimensions were. When we were exploring the dimensions of trust, the first thing we needed to do is analyze whether or not the items within each of those dimensions were a good fit. So we dropped items with ceiling or floor effects. We looked at standardized factor loadings. We looked at scale reliability to making sure that the items relate to one another in the dimension, and item total correlation to make sure that, again, that they're correlated to the dimension. And then after we were able to do the analysis of each of those dimensions, we also looked at the overall model fit to understand whether our data actually is plausible, if it fits the model that we had hypothesized. I think we have about a third of folks on the call who've responded. Let's see how close you got to what we found. I'm seeing that a lot of folks are seeing that fidelity or that commitment to patients, honesty, and equity. Wow, won't it be a surprise to know that honesty and equity weren't on that top list there? But that commitment to patients, fidelity, competence, and environmental quality all rated equally. So you're seeing that there's a high association with trust for competence, environmental quality, as well as fidelity. However, it is important to note that all of the dimensions of trust were correlated to trust. So it wasn't as though we got it wrong. I love saying that. We got it right. But that there were certainly dimensions that were more highly associated to trust. So what did we do with this information? Well, we took it on the road. We decided to go out to our hospitals and understand, well, what are you doing to get those high ratings of competence, those high ratings of fidelity, those high ratings of environmental quality? And as time allows, let's talk about community integration, since it was high up there as well. How do we pick our hospital site visits? So first, we looked at our survey. Use the data that you have on hand. Remember, we asked all of our patients to rate how highly they trusted their hospitals across 5 questions. So we used the data from that, and anyone that was above average was immediately qualified to be part of the pool. And then we cross-tab that with HCAHPS scores. We were looking for 4 or 5-star ratings on HCAHPS. And then finally, we looked at Yelp ratings. We know that Yelp ratings are not necessarily very prevalent, but are still have been proven in the literature to give an accurate sense of how patients are, and it's publicly available data. So we looked at a 3.5-star or higher rating on Yelp. If you were able to meet all those categories, we entered you into the pool and also considered whether you were public or nonprofit to make sure we were getting a mix. We wanted to make sure we were looking at hospitals with different bed size, and we also considered geographic location. We ended up visiting Ashkenazi Health in Indianapolis, Orlando Health, obviously in Florida, and UCLA Health Santa Monica in Los Angeles. We are incredibly grateful to our hospitals who helped facilitate this process for us, talking to both professionals and patients. At this point, we have another poll coming up. We, again, focused on some of the top dimensions that came up in the survey. We talked with 44 hospital staff, as well as 60 patients. We did 2 focus groups of 10 patients each at each hospital site, and we were able to take a tour on site. We gathered a ton of information, but I'd love to hear from you. This is the same poll. We need to launch poll 2 about what do you think came up repeatedly that was maybe a surprise to us? Are there any topics of conversation that you think that maybe we may have missed or not talked about that were a surprise?
So everyone should be able to see the second question if they scroll down.
Got it.
And that's the question that we're focusing on right now.
Thank you. Oh, they're all in one poll. Got it. I will give it a couple minutes for us to respond while I talk about some of our key site visit findings. And I'm not going to touch on those surprises in case you have a good guess about what came up. But we did have some key findings. I'm just going to touch on these at a very high level for us. One of those key items that came up was about organizational culture. That is, having a long history, whether it's decades or in some cases, even centuries of service across multiple generations. I delivered my baby here, my grandmother delivered my mom here, my mom delivered me here. We continue to come. We also heard at every hospital that we went to, that's really interesting that you picked us, because this is something that we continue to work on. We're continuing to try to figure out how we can improve, whether it's around dedicated staff or using other techniques of quality improvement. We also heard about equitable care and charity care. That is providing care to you even if you don't have insurance or you only have limited insurance, for example. We heard stories of patients talking to us about how person-centered the care was, that staff would come by and speak to them in their language, that they would be communicative with their family members who couldn't be present in the room, which has now become, of course, very commonplace with COVID, and knowing that visiting privileges, change over time. But in 2018 and 2019, when we started this work, that wasn't necessarily as common. We also heard about competent care, and that is getting those positive results, that my baby was able to leave the NICU healthy, that I survived my surgery and I'm thriving. And that all the information I was provided was up to date, and speed of service being a clear indicator of competent care, that I didn't have to wait for hours, that I was seen within 15 minutes of arriving. All right, so things that came up that we weren't surprised about: billing. Billing came up time and time again, and it was a topic of conversation both across staff and with patients, whether it's about when the bill arrives, getting a surprise bill that you didn't expect because your doctor or anesthesiologist, for example, was out of network. And on the staff side, we heard about having financial counselors and advocates to help patients walk through concerns and questions about billing. We heard in the hospital environment the discussion of having a clean environment, but also very highly talking about how important it was to have a single patient room, that it was meant you would have privacy, that it would be quiet, that you would have a bit more control to be able to rest and recuperate. Now, that surprise item that came up in that poll was parking. We didn't ask about parking, but every single site that we visited, we had patients rail and talk about the lack of parking, the cost of parking, and the accessibility of parking. So we know that that is certainly something that is related to trust of the hospital and important to patients. And lastly, we heard a lot about community engagement, whether it's those non-medical services and linkages to referrals in the community for food or housing, or talking about having hospital staff volunteer in the community, or community volunteers coming into the hospital to volunteer. We also heard about having hospital staff on community organizations boards, which I'll talk a little bit more about when we get to our guide. So with the information from our survey and from the site visits, we were able to put out a guide for essential hospitals to be able to build trust themselves. Now, in this guide is a list of recommendations and associated approaches to help build trust. This list looks pretty extensive, and I want to be clear that it is not a checklist in that I do all of these things, then I will achieve trust. You may not be able to do all of those things. Perhaps your hospital doesn't have single rooms. You can't just snap your fingers and suddenly create single rooms. And that's not what we're suggesting at all. These are all incremental steps that your hospital may be able to take to help build trust that you haven't yet. Kate has very graciously pasted a link to the guide in the chat box if you want to access it. For shorthand, it's just at essentialhospitals.org/patient-trust. Let's talk about what's in this guide. So in this guide, those 4 major recommendations are very closely aligned to some of the things we heard on site visits, talking about building an organizational culture, focusing on patient-centered care, cultivating that physical environment that supports trust, and engaging the community. Okay. I want to highlight, though, that this research, while done prior to COVID-19 pandemic, about what we found and the key elements within the guide can be used to build trust in the pandemic era. For example, when you think about person-centered care, thinking about advocating for equitable testing and vaccination is something that our hospitals have certainly been behind. Making sure to communicate with family members when they can't be present in the room is something we also touched up on. The physical environment becomes ever more important, as we know that standards of cleanliness and improved air quality can help prevent the spread of COVID-19, as well as single rooms. We know that having a waiting space for patients and their families as they're waiting to be seen in the hospital or emergency room or waiting to hear is going to be important as well. So making sure that they don't have to park a mile away and pay $22 to do so could help, again, whether it's acute, chronic, or during COVID-19. And finally, we talk about community engagement. During COVID-19, it's affected more than health. And I think we're all aware of that. It's impacted joblessness. It's impacted education. It's impacted housing and food. And so we know that having existing or establishing new collaborations with communities across different areas to address these social determinants has also been critical in the COVID-19 era. In the guide, you'll see some of the approaches to building an organizational culture of trust. Includes setting your mission to emphasize that equitable care, or creating that culture of continuous improvement. We heard folks talk to us about always looking to improve, looking at what other programs we have available to us. We saw physical representations of that in public Gemba boards, for example. We also talked to staff who had been there years upon decades and had said, I work here, but so does my daughter. And then finally, we talk about supportive leadership practices. That might include going around and doing some walk around management, asking frontline staff as a senior leader about what they're doing or what challenges they have, and then making sure that not only are you listening to them, but that you're going back and taking action when you're hearing it. We also heard about a focus on patient-centered care. We heard about tools like AIDIT and CI care to help engage patients. We also heard about how to reduce the financial burden on patients. For example, being sure to have staff on hand to answer their questions on site as well as after the fact that are dedicated just to that process. In terms of cultivating a physical environment, I want to draw back to something we just talked about related to billing. Not only is it a human resource, but we heard about one of our hospitals that decided to actually move where the billing office was from in the basement where you normally find it to being right straight on the entryway. So when you come into the hospital, where you would normally find the place to buy balloons and gifts is where you find the financial office. They actually traded the size of the office for where you buy gifts to the financial office, so there would be plenty of space to address that issue. So making the services that patients need accessible to the entryway, and that could be parking, it could be financial service, but really, again, that patient-centeredness and thinking about how you design your environment was absolutely important. You'll see here pictures where there's visitor space for patients to engage, including guitars and things of that sort, while patients and their families were visiting, as well as fresh fruits and vegetables in the cafeteria that we found out were not just helpful to patients, but also to staff who were, headed home and had a long day and were able to buy healthy foods for a reasonable price. Finally, we talk about engaging the community. We found that having these small group discussions was something that allowed patients to feel like they were being heard. We were doing it as part of our research project, but they were excited to continue to participate in similar types of discussions. We talked about sponsoring community events, whether it's a walk or a fair on site. But what we really heard most about was about these volunteer opportunities. Whether it's, again, having staff go out into the community and sit on a board that wasn't maybe familiar to them. Maybe they're a nurse, but instead of sitting on a nursing board, they're sitting on a board around housing. And then finally, I have to give it out to Coco, who's sitting here. Coco is a pup who is a volunteer at the hospital that went around to patients to help to provide support to them on site as well. So if you take nothing away from this conversation, remember that if you can get pups in and handle parking, you're already well on your way to building improved trust in your hospital. I'm looking forward to our discussion today. If you have additional questions, I strongly encourage you to contact my PI, Kalpana Ramia. Her email address is listed here. The guide is publicly accessible at the link below, and certainly I'm happy to answer any questions you have as well.
Thank you so much, Jennifer. That was a worldwide tour of lots of information and really appreciate it. Kate, if you could get rid of the slide. Oh, thank you. So I've got some questions for Jennifer and actually told her my questions beforehand. So we're going to have a little conversation. And thank you so much, Jennifer. Every time I hear that talk, I learn a lot more and it gets more developed. So thank you. So, so you asked us what surprised us. What surprised you, Jennifer, on the factors contributing to trust? What was your surprise?
Absolutely. So first, let me just say thank you for the opportunity to present this information to this audience and for being with us on the journey from the beginning. You were one of the most engaged organizations along the way and helped support this along its process. So thank you for that. Parking was a surprise to us. I did not expect to spend so much time on parking. But I also have to say, at the time of the survey, I was also surprised to see that equity did not come up as highly associated with trust as other factors did. And I think that that surprise may come from the fact that our hospitals have consistently, over decades, served members of the community that are sometimes less engaged. And so when we look to how do you address social determinants of health, I hear from hospitals who are not our members about how, who are much not quite as far along the journey and addressing some of those same issues. And I think that same thing may be true when we talk about that community integration and connectedness, when we talk about addressing issues of equity. The essential hospitals, while certainly still have work to do, are further along in that process than others.
Maybe it's fairness is a word that might ring true to everybody. One thing I always think about was you have these drivers and you've asked patients what the drivers are. But what do you say to the C-suite that says, that's good. I'm glad our patients think it, but, we're under pressure to improve our processes of care, our outcomes of care, and our financial condition. So why don't you go out and survey all of that and see if there's an association between the two? What would you say to that, Jennifer?
I think that's fantastic. We would love to be funded to do that additional research. And that certainly, it's true. We did focus on the patient aspect of this. But we know from past literature and research that patient trust has an impact. It means that there's greater access to care, that people are more likely to come into the doors if they feel that they're trustworthy. That automatically is going to achieve higher finances for your organization. We know that there's greater adherence to treatment and care for patients who have high levels of trust. And so that may ease the process for your providers and make sure that they have less follow-up to do. We also know that continuity of care is certainly associated with patient trust, as well as a higher self-reported health status. So if you can generate care, you will get better outcomes. Do I have the data to prove that? No, but the literature does show it. In addition, I do believe that patient experience at our association has been consistently one of the most important issues to address for our institute. We have an interest group, so if you are a member hospital of America's Essential Hospitals, we certainly encourage you to join our patient experience interest group to do learn from one another about how to improve that patient experience. And knowing that means that I know that patient experience and a subset of that is trust is going to be important to that C-suite.
I think one thing that a CEO would like to hear is more likely to recommend to a friend your institution. So here's my last question. Something I've been experimenting with is taking these factors that we think build trust and applying them to policy issues, such as accountability systems, measurement and accountability systems, payment systems. What do you think about that? You built your factors around the patient's trust, but we don't think about payment or accountability within a trust framework. But I'm experimenting with it, and I wanted to get your take on it, Jennifer.
I think it's an uphill battle, certainly. We know, for example, HCAHPS has been around for, over 20 years. And that changing HCAHPS is certainly continues to evolve over time. And we have had a great deal of impact on how those ratings are reported and how they're used for reimbursement and other measurement and accountability. I do not know that the appetite is there for this, however, on the policy side. But I do believe that there is potential value in always using user-centered or patient-centered data to do this. I also want to highlight a note that Dr. Ramia put in the chat box, and that our C-suite, our executives are also highly engaged in this topic. We were able to talk to 44 hospital executives and staff on site at our 3 hospitals. And so they are certainly here behind you in thinking about how trust impacts their bottom line. And I think you can certainly get support for this effort as you continue to look at it.
Great, thank you. So I've asked my questions. Now, what are your questions? And you can unmute yourself. And there is a within participants, there is a way of, I believe, of raising your hand. But you can also just, given that group is as small as it is, you can just unmute yourself and have a question. And if I don't get any questions, I will pick on people who I know and ask them if they have any questions. So be prepared, people that I know. Okay, Rich, have any questions? Richard Frankel.
Yes, first of all, thank you for that wonderful talk, Jennifer. And as Daniel said, there's a lot to learn. My question is around a different dimension of trust, and that is trust of physicians with one another. And we've done a little bit of work, some at the forum a couple of years ago, where we asked physicians about how much they trusted their fellow physicians. And especially in the era of the electronic medical record, which some people find difficult to trust. And it's being the de facto continuity of care these days. I wonder whether you looked at all at trust among physicians. I mean, there's a lot of research on physician-patient trust, physician-nurse trust, physician-community trust, but there doesn't seem to be much literature that we could find on physician-to-physician trust.
I think you raise an important issue. And as we were looking at what aspects of trust should we explore, there were many. You've named an important one in physician-to-physician trust. You also highlighted physician-to-nurse trust. I know one of our other funders, Public Agenda, looked at not just physician, how much patients trust physicians or hospitals like we did, but how much physicians trust what patients say, which is another interesting aspect to look at. That I hadn't seen much of in the past. I also know there are patient advocacy organizations looking at that as well, patients and physicians, bilateral trust. I haven't seen much about physician-to-physician trust, except to anecdotally, if I'm very frank, Rich, and I've heard some of the things that you're saying is that I don't trust physicians who aren't even in my specialty, for example, right? I think that these aspects of trust, these dimensions that we've looked at, are certainly applicable and considerable in other areas, though. I think that we could look at, for example, those issues of equity and community integration in that physician-to-physician trust, particularly across specialties. But so much of it is individual, right? And that relationship. And we saw that in that person-centered care piece. It's not, even though we're looking at institutional trust, a lot of it comes from those individual relationships that you build up over time.
Thanks. That's great.
Thank you, Rich. Any other questions before I pick on individuals?
May I pick on someone myself?
Yes.
I just want to give a moment to Dr. Ramia, who's on the line here today, my co-PI, to see if she'd have any additional comments to add to the conversation or to address some of your questions that came up about what was a surprise to us, factors that we could use for policy issues, or the impact that this work could have.
Thanks, Jen. I think one surprise that I would add from the conversations that during the site visit is the CEO's relationship with the community. The C-suite relationship with community is something that I was surprised to hear during focus groups. How I don't know the name of the CEO in the hospital, in the community that I love it. I don't know who's the CEO, who's the C-suite, none of those. But in the focus group, when I heard certain people's name and I asked them, like, how do you know them? And the patient's response was, oh, we see them in the events, we see them engaged, we see them in the fair. I think that level of engagement in community builds trust, which I was surprised not by the quantitative measure, but the qualitative facts that I was hearing from patients. As Jen mentioned, the interest in this work from our membership and the C-suite level has been very high. Not just for the patient experience, patient-centered care pieces, but also what we are facing today with COVID, with structural racism. All of these factors are connected and interconnected, and building trust makes a connection to each one of these topic areas that our hospitals and the communities that our hospitals serve face. So those are the 2 points I'll add. And Rich and Daniel, some of your questions about other forms of trust, other things that we should look into. We went in as an association that represents hospitals to think this is about institution. Let's focus on who we serve, which is the institution as an entity, and what does trust mean for the building trust with the community for this institution as a hospital and healthcare system. So
I should mention that I live in Indianapolis and work at Indiana University in Eskenazi, and I certainly hope that you were treated well. And I know the CEO is very visible in the community, and the hospital is has been a good neighbor to the community.
How did you guess that was the place that I was talking about from the focus group? It's one of the places that we visited. Yes, thank you.
And we were treated excellently everywhere, to be honest with you. We just had a blast.
Kalpana, thank you so much, and thank you so much for your support of this project. We look forward to working with you in the future. Any other questions? I'm going to pick on Leslie Tucker. Do you have a question? Now I know who's listening and who's not, and who's on the line.
I am listening and I am on the line. I've been privileged to hear this before, and it has been so important to informing our work. So I guess, Jennifer, what's next?
Great. I think that what's next is what our hospitals are doing. So one of our member hospitals took some of the early findings that we had and guidance and launched a trust challenge. They essentially had 38, I believe, of their clinics or groups apply for this trust challenge related to the dimensions that we had laid out in our guide. And they worked on a number of different activities. Some of it was that communication piece that they worked on more heavily. Others of it was developing relationships and referral networks. It was, again, it gave us structure and a framework for helping improve quality within their hospital in many ways. We are looking forward to continuing to promote this guide, using it as a resource in our policy and advocacy work, and then also looking to see how we can support our hospitals implement this guide and these recommendations, and testing to see what sorts of changes they can see as they're implementing these approaches.
I want to hold up this, you can't see it because I'm virtual.
Yeah, I can see it now.
This is from Parkland Hospital, who partnered with Essential Hospitals and invoked our name. I don't know why, except for the board member, the CEO is on our board, Fred.
Keep it in front of you, Daniel. because it's
There
like
you
that. Yeah.
So they had 80, this is an 86-page document, and they had 4 of them, and we're building a community of organizations who are submitting to us their trust practices. So this was just like, oh my God, this is a reality. This is fantastic. And, you know, I think we're going to dig deeper into what made these practices trust practices, and glean probably many things that you have gleaned, and hopefully new insights. So thank you for leading us into this arena, and really, I think, an incredible contribution
Can
from
I ask,
Essential Hospitals. Yes, Leslie.
can I ask a follow-up question since Jennifer opened the door to it, which is what on your policy and advocacy agenda may have bubbled to the top that wouldn't have otherwise if you hadn't done this work in this frame?
I'm gonna let Dr. Ramia answer this question, as she's closer to the policy and advocacy work than I am.
I would say, as I said, it's all interconnected in many ways. And last year in 2020, right after George Floyd's murder, our board were, both the boards, the association board and the institute board, committed to combating structural racism as a key area of our advocacy work this year and moving forward. And one of the pieces with building trust is highly connected to that, and it supports the work that we do on the advocacy side. We do not do this work by ourselves. We partner with other organizations. We work with Human Rights Center, AARP, AMA, and others as a partnership in working on combating structural racism, and openly talk about healthcare as an entity that needs to be fixed too. So trust plays a factor in it and helps this guide and this discussion, and opening up this discussion has been helpful in that conversation.
Thank you.
Great. Good question, Leslie. Thank you. Okay, any more questions? We've got some more time, or we'll give you back 13 minutes of your life.
I do have another question, Daniel.
Okay, where is that question?
It's here.
Oh. Thank you, Richard.
So we're doing, with some help from the ABIM Foundation, a study of what we're calling organizational professionalism. And we're interviewing a number of CEOs of Baldrige Award winning hospitals. And we've seen a pretty even split between CEOs who say, we stick with the metrics and we measure and act on the basis of the metrics and what we're measuring. And other CEOs who say, I walk around the hospital and I observe, and what I see and what I experience tells me how professionalism is playing out. So my question to you is, since you had both kinds of data, were there any surprises when you looked at the metrics for one hospital that looked great and you walked into the hospital and it felt different from what you saw? Or was there fidelity between the measurement and your experience in the hospitals themselves?
There was absolutely fidelity between the measures and our experience in the hospitals. I would note that we had 1,000 responses, but across 231 hospitals. So the meaning of, a small number of data points isn't as much as we would like it to be when we get on site. It's also important for me to note that when I think back to how our hospitals talked about what they're working on, we heard both of the things you're talking about. We heard that they had these dashboards and these measures that they looked at on the daily to impact how they provide care. But we also heard about the importance and saw the walk around activities. So when we were on our tour, we saw senior leaders that we later talked with walking around the hospital, engaging with staff. So it wasn't one or the other, it was both at our hospitals that we visited. And then finally, I just want to say one of the things that was important to highlight is that we didn't sit down with our patients in hospitals and hear, we're great, everything's amazing. That was not the story that was told. We heard very clear issues and concerns that came up with patients where they felt that they were mistreated or where the hospital had fallen down for them in terms of service, whether it was a misdiagnosis, a lack of engagement, or some other mistreatment of having to wait or pay a high parking rate or something of that sort. So by no means are the 3 hospitals that we studied at perfect. And we heard that from our hospital staff as well as from the patients that there's work still to be done, but overall those were highest rating. Dr. Ramia has something to add.
One thing I'll add for Rich's comment, we saw only 3 hospitals, right? And for each one, although the larger theme was the same, Rich, each one approached it differently in its own way based on the population that they were serving. The population that they were serving in Indiana was different from California to Florida, and their approaches were different. But did we see a same construct? Yes. But the methods used was much different. And especially if you think about, for example, California, it's on a larger health system. We visited 1 hospital within that health system. So the C-suite approach in a health system level was different from the hospital level, whereas Indiana, it's 1 specific entity. So that's another thing to think about when you think about C-suite leadership relation to both within the hospital and outside the hospital walls.
Thank you. Any other comments, questions? Okay, well, I think this is a wrap. We'll give you back 8 minutes. Jennifer, you're amazing. You are truly an amazing person, and this work at Central Hospitals, Kafana, congratulations to you and your team. It's just groundbreaking work, and I think it's going to have impacts for many, many years to come. So thank you. Thank you for your work. Thank you for being here. Kate Carmody wants to thank you all for joining, and join us again on April 20th for a webinar on tackling COVID vaccine hesitancy with speaker Dr. Sandra Quinn from the Maryland Center for Health Equity at the University of Maryland. And I look forward to that as well. Well, thank you. I hope you guys tune in again, and we're going to have some great speakers just like Jennifer down the road, and hopefully you'll be a part of this community. So thank you and have a great day.
Thank you.
Thanks.